Welcome, welcome.
Yeah, it's good to be here. Try to learn this stuff. Yeah, it's
How are
We
you
all
guys
are.
doing?
tell you what, I had my Vivides implanted about a year and a half ago, and we weren't doing LALs then. I kind of wish I had waited a little bit.
Yeah, that's not an uncommon thought, I feel.
So have you any of you guys have experience with explanting after like a year and a half and putting a LAL in?
We've done it, yeah, a couple times.
So is it a crazy idea?
No, it's
Nope.
good. Yeah, the
Nope.
patients
Yeah.
love it.
I mean,
Yeah, we've inherited patients from clinics in our town that did Panoptics or whatever, and just unhappy outcomes with glare halos, and we've explanted, no problem. Surgery goes smooth as long as the capsule's intact. Getting the lens out is usually not a problem, and then it's just it's cake after that, just like any other LAL.
but hey, Nick, I would even argue that we had a patient recently, and she has Marfan's, and I was worried. I had a patient years ago, it was a nightmare, bilateral recurrent vitreous hemorrhage from UGG, from subluxation in a Marfan's patient 20 years after surgery. It was crazy. And so with the Marfan's patient, because it's a silicone lens, you can put it in the sulcus. So even if the capsule's not intact or it gets breached during the explant or the exchange, you can still put it in the sulcus and, without worry.
That's a good point. And it functions just fine. It functions fine in the sulcus. I mean, we've had plenty of patients.
We had one like that.
Yeah.
It had to be in the sulcus, and it went great.
Yeah. Well, let's kind of get started here with what we want to talk about. We want to go through cases, so kind of a continuation of the last meeting we had about a month ago, which really turned into some great discussion. I think we had 2 cases presented. We had 5 prepared, and we only got through 2 of them because of the discussion. So, again, this whole forum is really supposed to be discussion. It's not a lecture. It's not just a couple people talking. We want to have everybody involved. So, Jess, if you want to take the lead on your case and present it, we can talk through some stuff and how you went through things and challenges that you had.
Yeah, I'd love to start us off. So I'm going to go ahead and share my screen here. Okay. Can you guys all see the PowerPoint slides?
Yes.
Yeah.
Okay. Awesome. We'll see if I can make this a little bit bigger. Okay, so this case I wanted to bring up is a little bit more complicated case that I had that I thought would be interesting to bring up, just because I feel like it's easy to just go through the straightforward cases, the straightforward patients, the ones where you're just doing a typical easy blended vision with that have virgin corneas, healthy eyes. So this is a patient that came in at their cataract consult and just was a little more complicated, had moderate glaucoma in her right eye, severe glaucoma in her left eye, and intermittent alternating esotropia that happens at distance occasionally. And she has a pair of 5 prism diopter base out prism glasses that she wears for that, and then some chronic dry eye as well, just from being on the glaucoma medications long term. And so we had her on Restasis, dry eye treatment as well, and she wanted as much glasses independence as possible. So this was her vision uncorrected at her console, as well as her spec RX. As you can see, she was a moderate myope with some astigmatism, and then that good near vision where she would take her glasses off to read prior to cataract surgery. So she came in at her first visit after we implanted the light adjustable lenses for her first adjustment. Her vision in her right eye was 20/70 +2 J10 near, left eye was 20/20 -2 J16, mostly coming from her astigmatism, as you can see the MR there. But as you can see with the MR, couldn't really refract her right eye better than 20/30 +1. Her left eye was getting to 20/20. Her chief complaint when she came in was the classic chief complaint we often hear at the first adjustment, that distance is better, but my near is terrible. I have to use my readers all the time. So because our surgeons will typically target plano, and then if they have any astigmatism, you know, they're going to struggle a little bit up close. And just to let you guys know, this is the standard LAL, not LAL plus patient. So just the standard LAL. So at this visit, checked her eye dominance. She was right eye dominant. And then because of her vision not refracting to 20/20 in that right eye, I typically go through 3 things when someone won't get down to 20/20. I'll go through cornea, capsule, and retina. So cornea, I'll put fluorescein in. You'll look for any staining. And then capsule, look for any early PCO. With this being a silicone lens, I do find that patients, it's not uncommon to have some early PCO during adjustments and having to YAG mid-treatments. And then the third thing, I'll look at their retina for any early Irvine gas. This patient's macula was spotless. Only thing was just the dryness. So went ahead and talked through options. We postponed that right eye though because of the dryness. She was really eager to do some treatment on her left eye though to get some near vision. So we talked through options. We could do a blended vision, but because of her glaucoma visual field loss, she may not adapt to it. She had a superior arcuate in her right eye and then a superior and inferior arcuate in her left eye. So no central scotoma in either eye, but definitely some peripheral field loss that I thought could make her have a harder time adapting to the blended vision. We talked about distance vision. With that though, as you guys know, with standard LAL distance, you'll get some intermediate, like dashboard, things like that. Some, maybe some near, but probably some readers within arm's length. And then the last option we talked about was near aim for both eyes. Since she gets intermittent diplopia at distance and has to wear those glasses for distance occasionally, we figured that would probably be her best target. So we targeted looking for near aim, you know, eventually maybe a -1 for both eyes. So start with the target of -1 on that left eye, and then increased her preservative-free artificial tears every 2 hours and started on Lotemax SM twice a day just for the dry eye in both eyes. And just before I go to the second visit, I just want to get anyone's feedback on this so far, just because I felt like this was a really interesting first visit. What's everyone's thoughts when you guys have a patient that comes in and you are able to refract to 20/20? Where do you go to first?
Hey, Jessica, can I interrupt for a second?
Yeah.
Ask a question just for some clarity about, do you see these patients preoperatively, or do you see them when they're ready to be adjusted or postoperatively?
We have a mix. So this is actually a patient I saw preoperatively with the surgeon.
Okay.
I think you did everything that I would have done. I mean, I have the same pattern. You know, you look at the cornea first, make sure that the stains, you know, minimal if any. Capsule always, it's a silicone lens, so you tend to get PCO a little bit earlier with this. And then I always get MAC OCT. My techs are kind of trained if they're not able to see what we expect them to see, especially if this were a second treatment and their target was plano, they should be about 20/20. But if they're not there, they know, just get an OCT and check that out to make sure that we're not running into CME.
Yeah, that's exactly how we do it too. So I would have looked at the same things, gotten the OCT, and looked at that cornea and looked at that capsule. Absolutely.
I do have a question about, you know, because she's dependent on Prism and she wanted to be out of glasses. Personally, I would have been reluctant to do this patient because of the severe glaucoma. I mean, there's a whole litany of things to me that is kind of a red flag. And if her goal is to be spectacle free and she's amblyopic and she's wearing Prism, I'm not sure I would have proceeded or recommended this lens for her.
Yeah, this was a tricky one. Definitely not the ideal patient, but someone that was really, really motivated. And at the consult, we did talk about how because of her double vision, and she only gets double vision at distance intermittently. So we did talk about that, and we mentioned she's probably, this is not going to get rid of Prism glasses or the double vision, but she was just very, very motivated to still have she wanted good near vision, but to be able to maximize distance as much as possible. So she is like at home and watching TV and not getting the double vision. She doesn't have to wear the glasses, or just to have somewhat more functional distance than she had preoperatively. And she was like, finances are not an issue. She's like, I will pay whatever I need to. She's like, I just want the best that I can have. So definitely not the typical best, candidate, definitely a harder, challenging case, but you'll see at the end that how cool her results are. That makes you want to consider some of these patients, although it's more work on our end doing all the adjustments. So, but yeah, let me go ahead and go to the second visit here. I'll show you guys when she came back. So second visit, she came in, we had only adjusted that left eye. So she now was plano in that left eye, 20/20 J10. She said her near vision improved a little bit, still was needing readers. I find when a patient has a lot of astigmatism, that first adjustment will treat, majority of that astigmatism. You won't see the near really come in too much with that first adjustment. So the right eye, her vision went from 20/70 at the last visit to 20/60 just with the dry eye treatment, but still was only MRing to 20/30. So again, postponed the right eye and again targeted -1 on the left eye. When she came back at visit 3, she said the classic line too, once you give the patient the near vision, they're like, well, my near vision's better, but no, my distance is worse. And she said, struggling with the difference between her eyes as well. But she really liked the near vision. She was happy with the near vision. She wanted to ultimately match her right eye for the near. The interesting thing with this, even though I targeted -1, she ended up at -2. So I didn't do any other treatments in the left eye. I wanted to see if this was stable at her next visit. So I held off. She was happy in that eye too, just focused on dry eye treatment, and finally was able to MR the right eye down to 20/20 -2. So we finally did an adjustment on that right eye. Typically with the light adjustable lens, as you guys know, it's rare that with a near eye you go more than a -150, -175. But I do find with these moderate myopes, sometimes they like going up to the -2, -225. And if they're happy, I'll sometimes keep them at that near point. So for the right eye, since she was happy with the -2, I targeted -150 originally. So before I go to the next visit, I just want to get your guys' feedback too on this slide, and targeting, near eyes, what your guys' experience is with maybe these moderate myopes, how nearsighted you guys have left patients, some of your patients.
My only thought, especially, so going back to visit number 1, if I have patients like this where one eye is just not up to what it should be, do you guys ever just do a plano target? Because what you're doing is, inducing that added spherical aberration. You can't undo that. And eye dominance, in my experience, switches. If I think somebody's a right eye dominant, but they come out and their left eye is just superior than their right eye, we can sometimes flop it. And so we want their best visual potential at their ultimate target. So for most people, that the target is going to be plano or a distance target. So this patient maybe is an exception. But did you give that any thought, Jess, to maybe just leaving it a plano target to begin with and leaving all options on the table?
I think that's a good approach as well. I think for her, I had a feeling with how much astigmatism she had that she wouldn't really get to that near target yet anyways with this adjustment. So I figured she'd kind of end up around plano, maybe a little nearsighted anyways, and we'd see how she did. But typically I still will target the full -150. And then any other thoughts on that slide?
Yeah, question. So you guys all think about, so I mean, if you're looking at that that right eye and the one meridian with a target of a -150, you're looking at whatever that is, 3 1/4 or something of a treatment, correct? +175 to 150. see what I'm saying, in the right eye with -1 plus 175. How do you guys, I mean, how much do you feel on a typical treatment you can get with an LDD?
On the first treatment, sometimes it's hard to predict what the machine's going to actually do. Sometimes I'll see where it tackles the astigmatism of the cylinder and it leaves it myopic. And other times I'll see that I don't really know, and I don't quite understand the physics behind, or the IT behind it. But I always try to pick what I try to guess, and I'm wrong almost all the time. But I will say that seeing that nice 090, that access, with the rule sill, that's like a safety net. So I see that, and I know that this patient, you're probably going to leave happy no matter what happens, because it's with the rule, and she's going to definitely get more depth of focus, especially if her demand is up close. If that's what she wants, she's going to get it. So you've already got it in the bag. Now
Well-
it's like you want to get the numbers right.
How is this patient functioning? Because as you're changing, this kind of reminds me of like the CRT lenses, when it's like they're mid-treatment, they don't have a pair of glasses to wear. So is she not driving? Cause that's just a little worrisome that she's 2100 in her good eye now.
Yeah, so that's a great question. So this patient, her husband drove her throughout all of her adjustments. She wasn't driving and she was retired. However, I have had a patient similar to this who had to drive herself to every adjustment, and she was driving like an hour. And what we did for her is we had her go to an optometry practice that makes glasses same day. It's kind of like a lens crafters. It's called iMart. And she got just some single vision distance glasses for $60. And she just got them made. So I wrote her, and since her prescription was changing so much, I wrote a temporary prescription for what I thought she would end up around. And in the end, I think she was like maybe 0.75 or 0.5 off in one or either eye, but at least that gave her some glasses that she could see to drive to get by until she was done with all of her adjustments. But yeah, these patients were the ones that you do leave them with a little near vision. I've done like -1 in both eyes, or something like this. You could definitely write like a temporary glasses prescription, have them go somewhere where they just get cheap pair. I'll tell them too. I'll be like, get the cheapest frame, don't spend too much on it. And just take this prescription with you, fill it out, and then that'll get you by during your adjustment process.
Do they ever complain that, they just spent so much on the lenses and then to have to purchase glasses? Like, I think that's kind of, or have they just accepted it?
Yeah, I've only done it like maybe the only one I can think of is that other case that I had her go to iMart, and this one she fortunately was retired and had a husband that drove her everywhere. So those are only two cases, but the other patient though, she was a little upset that she had to get some glasses, but after she got them and they were functioning for her, and she was like, they were only $60, she ended up being fine, and in the end was really happy. But she was a patient who during the process though was really unhappy because she couldn't see safely to drive. So I think once she got them, she was so happy that she could feel safe to drive that she didn't care about the cost.
Mm-hmm.
Yeah, Jenny, I've had somebody where we sent back to the referring doctor and told them to make the cheapest possible glasses, and we just paid for it. We just ate the cost of the glasses,
Mm-hmm.
That way the patient was acceptable. They were not unhappy that they didn't have to pay extra money.
Hey, does anybody else?
Jessica.
I was wondering that too. Does the patient take the financial responsibility for anybody else, or do you guys pay as a clinic? Anybody else?
Sometimes I've just given them like a contact lens. If it's, I give them like a spherical equivalent of a contact lens and been like, okay, you know what, you can try wearing this for like a week or two, and like this should kind of fix up your reading or fix up your distance up until, let's say your dry eye gets better, or we see the results for the next one, So sometimes I've had patients that have had very severe like SBKs, and I'm like, there's no way I'm touching your eyes just yet. So I'll give you a contact lens. This kind of helps with the SBKs. It's going to help with the dryness a little bit. and it's going to help with the vision because I can see that you just need a bit more for reading or a bit more for distance. Like if they have like a myopic outcome, if they have like a myopic outcome right from the surgery itself, like a -75, -1, like okay, here you go, right? Like here's like a -1 lens, just let your eye kind of heal a little bit, and like, and then we can go from there. And they really appreciate that.
Yeah, I've used a contact a couple times. I haven't had anybody go buy any glasses, but I haven't had a case quite like this. So, yeah, I'm learning here. This is cool.
So Jessica, I just have a question for you for this.
Yeah.
Now, if you target in your, I just want to make sure that the right eye's like end goal target is to be plano. Is that correct?
So the right eye end goal is to be -150. But
Oh.
yeah, but I don't imagine it to get to the full -150 because of how much astigmatism this patient's right eye has. And we talked about a little bit a minute ago when we were talking about how much it's hard to predict exactly how much astigmatism it's gonna, or how much is gonna be treated with the first adjustment. But I find if someone has 1 to 1.75 or so of astigmatism, it treats that first. And before, and maybe some of the spherical component, but it doesn't typically get to a full target with that. So like Nick was asking, like, why not target plano first? I think you definitely could. But I just figured that this patient would probably end up around that, or maybe a little more nearsighted, but not at the full 150 with this adjustment. So I just put I put -1.5 actually in the LDD. And I think with that much, I might even got that notification that says your outside parameters, and you can still just click that's okay and treat. So that's why
I think I missed your previous slide for a second. I just wanted to make sure. So yeah, okay, so you are targeting your the left eye to be plano, or wait, so does this patient want both eyes to be myopic?
Yeah, so this patient wanted, this is a weird,
gotcha.
A weird case where she wanted a near aim in both eyes. So my original goal for her, and how we all know sometimes our original goal is not always what the end target ends up being, but my original goal was thinking -1 for both eyes. I've done that in a couple other cases, and those patients, they can drive during their adjustments, because a lot of times if they're -1, they'll still be 20/30 or better. But this patient obviously didn't end up at the -1. She ended up at a -2. So her vision was worse in distance, and also she was really dry. So her distance was even worse than what I would expect, because we're battling her dry eye throughout these adjustments as well. But yeah,
Can I ask?
go ahead.
Oh, quick question about these patients that are going into surgery with, maybe like at least a diopter and a half of corneal sill, or maybe you're expecting more. Are any of your surgeons doing an LRI, if they're doing laser assisted surgery, to kind of cut that down? I met a surgeon in Florida who routinely does that if there's even more than a diopter of corneal sill, because she said it reduces also the number of adjustments needed.
Yeah, I think that's a great question.
We do it, absolutely.
Yeah, Nick's practice has done that. We, at our practice, we haven't, but Nick, you'll have to tell her
we
how
do
you guys do it.
Pretty much standard over a $1.25. We'll do an LRI or an AK. We use a LEDSAR system. The problem with patients like this, where they're super dry, is pinpointing the astigmatism and the access to treat preoperatively can be tough. So it may have been, depending on what the pentacam actually looked like, or depending on what the actual corner looked like, it might have been hard to do that. So, but we do routinely 1.25 and above. We'll do it, because that also leaves more macromers to treat, so you can get more myopic if that's the way you want to go.
Absolutely.
So,
Hey Nick, does that delay your LDD treatments when you do femto LRIs?
No, we still do it the same clip. It's at 3 weeks. We do our first one.
Did
if
this
there's
patient
a wonky,
have any?
yeah. Oh, go ahead.
But did this patient have any option for a goniotomy or anything like that to maybe reduce the dependence on the glaucoma drops with the dry eyes or?
Yes, great question. So I did not put that in here, but yeah, she did end up having eye stent injects in both eyes. Or eye stent injected in her moderate eye and then Omni in her severe eye.
So just so let's say like if this patient here who's left eye at -2 and she's like, hey, you know what, my reading is great. Why don't maybe I want actual distance for my right eye. How would you go forward from here without inducing the spherical aberration bump?
Yeah. So if that were the case, I would just target I would target the plano for the right eye.
So like
Yes.
even though like it's gonna fall outside of the parameters for the LDD?
Yeah, I would still target the plano. And even if it's outside the parameters, it just may not get there with this first adjustment. So I might
Gotcha.
need 2 adjustments rather than just the one to get to the plano.
So I had a similar case like this, but it wasn't -1 and +175. For me, it was actually +1 with +175. And that patient, I had to convert him to plano. And I'm not sure if you remember, maybe not the last talk, but the last talk before that. I asked, hey, so if the machine says really gets outside of like the parameters, do you just click yes, or do you change really your input? I believe everyone pretty much says you just click yes and just move on.
Yes.
Yeah.
But I changed my input for that +1 with +175. I put the input as in plano with 175 and just targeted that 175 sill to plano because I didn't want to. Again, like I just wasn't sure if I can go like more than the parameters for the LDD, and that patient ended up their subjective refraction ended up as -0.25 with 125 sill. And then from there, I went to plano and they ended up being basically plano afterwards. Have you guys ever done that where you're kind of just, okay, cool, I'll hold the sphere. Let me just like solely target the sill and then target the sphere afterwards. Has anyone like ever been in that situation?
I
That's
feel
not a
like
bad
we're trying to
idea.
just limit
I never-
like, why not just throw the whole kit and caboodle at it, like instead of you put the whole prescription in and see how much that treatment's gonna take, because
Okay.
if your ultimate goal is gonna be plano, we know it's gonna target the sill first, but if we're lucky, it'll chip away at some of that sphere too. And then the patient is gonna have less treatments. Less is more with treatment. So the more you can get done with the first, and the first treatment, you're gonna have the most impact on the patient. So don't hold anything back, even if it says it's out of limits. It is out of limits.
for
but it's
that
gonna target
patient,
you.
So for that patient, right, like when I click, actually for some of the patients where I'm like, okay, cool, right, like I'll just click yes. The treatment time ends up being like 152 seconds.
Mhm.
And that one, I'm just like, man, it feels like it's too long. Maybe I'm burning too many monomers. Like, right? Like when I see 152, I mean, that's more than your second lock in. And I'm just like, I just don't feel comfortable going anything more than, I don't know, like 122 seconds. So like, has that 152-second treatment worked out for you guys, like in a similar situation?
I see
Yeah.
what you're saying though. That's not a bad idea. I mean, I've done that before, and we just do pedal to the metal. We put the whole target in, and we usually get there. But I see where there might be an advantage because I don't quite understand how the macromers work. I don't understand to a super high level how the physics work. So if you're trying to just treat the astigmatism, maybe there is an argument for more regular movement of the macromers. Maybe that is true. I don't know. That's a good point though, and I think maybe a good strategy, or at least
So
an
basically,
arguable strategy.
I would say like over the past few months, I've been really trying to like observe the pattern of the of the treatment that you see on the eye itself. Um, I guess I pattern all of the UV that goes onto the lens. And when you're really trying to target just the still, so if it's like +1 with +175 still, and I put in Plano with 175, right, and I target that, I've noticed that the UV light is very much it's a lot more focused at that particular meridian that you're trying to get rid of, versus if you're doing, let's say, +50 with 150 still, and you're trying to aim into Plano, I've noticed that it becomes a bit more diffuse and I get a lot more still basically like left over. Again, that's just me like trying to find out basically patterns in the engineering of it. I don't know if anyone has ever basically come across that.
I've noticed that too. And I think the theory of why a myopic treatment is easier than a hyperopic treatment, because you're focusing on just the center part of the lens. It's a much more compact area and focus spot. So you can trick the LDD. I mean, the LDD is listening to what you're putting in. So if you do try to just take out that cylinder, I could see that being an arguable strategy, and it may work better. I've never had to come across that. I've had good success doing it the other way, but I see where your head's at. That's not a bad idea.
Can I ask a question about the prism on this patient?
Yeah.
Did she end up needing less space out prism because she wasn't as nearsighted? Did anything like that happen?
So basically in the end, she wasn't really getting that much diplopia, so I don't actually prescribe her prism glasses. So I sent her back to her referring doctor who did the prism glasses. So I don't know if the prism ended up being, where it ended up being at Aptus, but I could find that out and let you know.
Oh, that's okay. I was just wondering if she needed as much.
Yeah, I think that's a good question though. I should look into that and see how she's doing now. So, but we'll go on to the next visit so I can show you guys the end of this because it's pretty cool. So at this visit we targeted the -150 on that right eye since we're finally getting to 20/20 -2 with some regular astigmatism. And this was the case we were just talking about where that right eye only got to -0.5. And so she ended up 20/25 +2 J5 -1 in that eye. And the other eye, again, the vision improved just with not doing an adjustment on that left eye and taking some time for the dry eye. So now she was 20/50 +2 at a distance, J1 -2 up close in that eye. And then OU was 20/25 +2 J1 plus. And she was overall really happy with her vision, and she's like, I'm only using readers when I'm crafting and doing like little beading and activities, fine detail up close. She was so excited. And so even though we were targeting -150 for that right eye, she ended up with less. And how a few of you guys asked, did you consider targeting Plano? It was a good question because she ended up, less nearsighted than what I was intending and being really happy with that. And so ended up with almost like a monovision, but a more nearsighted monovision, more nearsighted focus. And so she just used a +1 over-the-counter reader as needed when she was holding things close, like she would with, her moderate myopia prior to cataract surgery. She was able to do that with just a +1 over-the-counter reader. And then at a distance, she didn't really even feel like she needed glasses, but she had, she could get some prism glasses made that we talked about after surgery if she struggled with the double vision. The only issue I had though is by adding the Lotemax SM, her pressure was creeping up a little bit, so we had to discontinue that. But because of her increased dryness, I ended up adding a heat mask and some Refresh PM. And then she came back for her second lock-in and vision was even better, just continuing to treat the dry eye. And she was 20/20 -1, J1 plus -2 OU, and was really happy overall. So just thought this was an interesting case because it's not your typical patient, maybe someone you wouldn't consider for the light adjustable lens, but someone who was just really happy that we didn't rule her out as not a candidate, and we gave her the ability to have the best technology, and end up being really happy. And when we locked her in, she hadn't had very many episodes of the double vision where she felt like she needed to get the prism glasses, but I did send her back to her referring doctor. So we always do a final post-op check with them in about 6 to 8 weeks, to be assessed for driving glasses with prism.
Is that a typo? 2030 at -2 uncorrected?
2030 +1.
Yeah.
J1.
Yeah.
No, that
Holy
was
cow.
it with a -2.
That's incredible.
Yeah.
Jeez.
So
Nice work.
Yeah.
That's awesome.
That's some really cool vision with that combo.
yeah, it's
That is
not a
yeah.
typical case, that's for sure. But just shows how sometimes the atypical patients can end up being some of the happiest ones, and why this technology is so cool, because it's so customizable to every patient. And so yeah, -2 is typically not, I don't love targeting that, but there's some patients where they're moderate myopes prior to surgery, they take their glasses off all the time, they love that -2 J1 plus. So, and she did fluctuate a little bit just because of the dry eye, so fluctuating between J1 plus -OU to J1 plus. So I imagine once everything stabilized at 6 to 8 weeks, she was probably doing even better, believe it or not. But pretty cool case, so I had to share.
And
So
it really
for-
sounds like she had some good expectations too, like you set some realistic expectations with her. Makes a
Yeah, I
big-
think that's helpful, seeing these patients. And I don't get to see all of them preoperatively, but the ones I do get to see preoperatively, I enjoy so much more because I know the conversations I've had and the expectations I try to really set with them on the forefront. But she was one of those patients where she's like, I don't care about the money. I want the best technology. I don't care about the health of my eyes. She's like, I just want to have the best thing. And I said, okay.
So for this patient here, like now when she's wearing her glasses, her vision for distance is great, but she's had this spherical aberration bump for both eyes. Has she like ever complained about what her vision is like for distance with her glasses with that spherical aberration bump?
Again, I haven't seen her after this visit. We release back to the referring doctor once they get the glasses. So I would have to follow up and see from the referring doctor how she's doing, but I haven't heard back, which normally is a good thing.
That is usually a good thing.
It's a great
And for someone like this,
A question.
like, would you have ever
Question, please.
considered? And for someone like this, would you have ever considered to do like an LAL plus?
So we're definitely a lot more conservative on LAL plus right now. So anyone like this, we would leave to LAL. LAL plus we're only doing on virgin corneas with no retinopathy, and then we just recently started doing on myopic LASIK patients. But we're definitely more conservative with LAL plus. This is me being definitely not as conservative. But LAL, I feel like you can have that, the standard LAL, you can have that leniency, which is nice. But I probably wouldn't use this patient with LAL plus.
I'd probably agree with that. I think I would have stuck with an LAL, just a patient who's got a higher likelihood of being less than 20/20 from the get-go. I usually lean LAL for those. Cool. Great case, Jess. I think that's awesome. I mean, it's incredible that you can get that much reading, and it's always a nice, pleasant surprise. Because I've had patients like that too, where they're just gung ho. I want to be nearsighted because I have all these high near demands. And then actually, once you get down to the process, they're like, well, maybe I don't want to be that nearsighted. And the customization is just super, super cool and very rewarding too. I mean, you get to be these patients' best friend, which is so fun.
Yeah, for sure. And I feel like the biggest thing I learned from this is just postponing, because her stigmatism, throughout there changed and a little bit. And, had I made the adjustment originally, I could have, made some mistakes with the refraction. So I feel like really just postponing makes a big difference and focusing on the dry eye treatment.
How long did it take? So when were you done? Like your whole process then? Is it weekly you go, right? Typically?
Yeah, we do once a week. And so I saw her for 5 total visits. So over a course of 5 weeks.
That's not bad.
Like,
I mean, yeah, that's not bad.
in terms of actually doing like the near targeting, so I've noticed that at times, let's say if a patient is, I don't know, -50 and you want that -150, I've noticed that like at times they just don't land at that 150 unless if I actually aim them to be -2 on the on like the LDD. Like does that occur frequently for you, where the patient, like, I mean, like you've done, let's say, 2 adjustments and they should have landed at 150, but they just don't get there, like they just like at the very most -1 and then they're just stuck there after 3 adjustments?
I've seen that before too. You almost have to kick with the wind and shoot like to a -2.
Yep.
You kind of have to trick the machine a little bit
Yeah.
in those cases. And I've seen that work where I've done like I've been at -1, we're trying to get to 150. I'll target 150 and they come back and they're still at -1. And then, well, okay, let's give a little more gas and go to a 2. And it usually gets to, as expected, about -150. You can usually get half. And I don't know why that is, but it's
Yeah, like I mean, like I was just about to ask him, like, is there like a rhyme or reason for it, or is this just it
I
just doesn't
probably.
go?
No,
No,
I just call it a stubborn lens.
it's a stubborn
I don't
one.
know.
It's a stubborn one. It's like it's the worst when you have that from a patient that's like, expecting like, and plus they have no patience at all. And I mean, like I have one, I'm just literally looking through a file, and and in the first 2 adjustments, I targeted for, so first adjustment target for 150 did not happen. I'm like, all right, cool. 175 did not happen. I'm like, oh my God, 3rd adjustment. All right, let's do this. Target for 225. I hope I get to 150. And I think this patient should be happy with that. But let's see. She's coming in tomorrow.
Good luck.
Fingers crossed.
Yeah. Fingers crossed.
those-
And she is one of those patients that like, I'm sick of this. I want to get done with it. I'm like, okay, hold on. Plus she has like dry eye. So, speaking of the dry eye, do you guys go like one step at a time? Like as in, okay, cool, right? Like you do your lubricating drops for like every 2 hours. That doesn't work. Or like then you have the Lotomax. That doesn't work. Then you have the warm compress. Or do you just throw the whole the kitchen sink at it?
I think that's a great question, and something I wanted to talk about as well too is just hear what everyone else does for dry eye. I think I base it a lot off of how bad the dry eye is. Like if it's 20/20 -2 or something, and I'm just not feeling it, like it's consistent, I'll do increased every 2 hours on the tears. But if they're not refracting to 20/20, it's like 20/25 or 20/30, I'll hit a little more aggressively and do the tears every 2 hours plus low to max. SM.
Yeah, I'll put them on. I've used even like things like Mibo or Vivi, one of those. And I try to catch it before surgery. If they have any staining or anything, we treat that and then repeat our pentacams, before. So the patient already knows going in. There's much more compliant after surgery to keep things going. But yeah, if they're not correcting to 20/20, I'm gonna get aggressive, because why string it out? In my opinion, is let's just hit this. And
I also ask the patients, how do your eyes feel right when you wake up? If they're already dry and grainy, then add an ointment at night before they go to bed. I don't want to start off
that's a great question to
trying
ask.
to play catch up.
Yeah, we've had success with serum tears too, for these patients because it's pretty easy to get them. There's a lab locally that does it within an hour, and there's no like therapeutic. I mean, it helps the longer you use it, but it helps pretty immediately. So you don't have to wait like a week or two, and you can really get going quick with serum tears. So we've had success with that.
As long as you have a good lab.
You gotta have a good lab.
Who's in
Yeah.
ours?
You don't do the blood draws yourself, Ken?
No.
Yeah.
People frown on that. I don't know why.
Yeah. Just hold still. Just hold still. No, we have a good lab that we use, and they're quick, they're reliable, they're relatively cheap too, compared to some of the other RX drops. So that's been pretty good for us. And patients who are stubborn, and it depends on how much they want to put into it. Most of the time, if they're in this far, they've spent the money, they've spent the time, they want to get it right. But every once in a while, there is the patient that I come across who's just super impatient, even though we've set the stage perfectly. I've talked to him, my surgeons talked to him, and we've tried to set expectations from the get-go. Sometimes they just still don't get it, and they want to be done. And I tell them, we can be done. You can twist my arm. We can be done with this tomorrow, but you got to release me from any accountability, because I am not recommending we do that. You're going to be unhappy.
I have a
You know, guys,
question. Oh, sorry.
no, I was just saying, we've been doing multifocals forever and seeing lots of very happy and unhappy patients. And all the reps always come in saying, you need to start every patient you do cataract surgery on some type of whatever their drop of the day is. But I think it wasn't until the LAL that we actually implemented that for these lenses. We don't have a dry eye service or a specific, but I do have one doctor who likes that challenge. And I'll probably send more patients to her pre-op to get a regimen that works with her and with their insurance first before going through it, because I found that by doing that, my time with them afterwards is so much cut in half or thirds, because they're not treating today because it's too dry. And we did that probably half the way. After about 100 lenses, we implemented that. And over the last 200, I don't think that I've had a handful that we've delayed treatment because of dryness, which has been so much more effective and so much easier. Coming in upset 2025 3+ SPK because they're on generic drops. It sucks. We're waiting 2 more weeks. So I think at that time, and even they know going ahead, since they saw somebody else to get that under control ahead of time, you're going to spend 10 grand on these lenses. Your eyes better be in the best shape possible. You're not going to put you're not going to put cheap gas in a Porsche. I'm not going to get cheap drops to try to get you through this. So that's the one. This is the one lens that I pretty much have set clinical standards that they need to be on some type of regimen ahead of time and believe in it and do it. So it makes it my job easier later.
How are people screening? Are people using questionnaire other than staining the cornea maybe, but anybody doing like tear lab or any point of service test?
We used to have all that. I probably see 95% of the cataract evaluations myself and my residents. So if it looks like a cornea that I'm going to have any difficulty with whatsoever, we're going to go for a couple of days to a different service just to make sure. And it's not even, half of it's not even charged. We call it a pre-op evaluation with our dry eye specialist, just to find the regimen that works better. And I think we've saved a ton of clinical time and clinical money doing that, because a little bit of SPK here, neurotrophic keratitis, whatever the issue is. We do a lot of curettage for EBMD as well prior to, just to resurface the cornea and get that in better shape, because I find that's probably one of the most difficult things to treat afterwards. Is you got very little seal to start with. Now you got $1.50 post-op because they have corneal edema or swelling or epithelial sloughing. So anyway, prevention. What's an ounce of prevention, a pound of cure?
Yeah. And may have a preference on what kind of, like, over the counter. I mean, because we have everybody on a regimen of preservative-free Ivisia. That's just our preference. Anybody else have any preference or reason why they like a certain OTC option?
I like
Oasis.
I like Oasis. It's probably the only one that, I mean, the other ones are good, but that's probably the only one that there's been no patients that are like, it burns. Like if they're having problems with the over-the-counter ones, and we're like, we'll try the Oasis, and then they come back, they're like, oh, it is so much better, like lasts longer. I don't know if it's just a little higher quality.
Hey, do you guys get this in your market, in your area? Hilo?
No, I don't. I've never seen that. No.
Yeah. Okay. So I guess this is just a Canadian thing. So yeah. So this is what we get, right? Hilo. I mean, they have like different, I guess like different like gradings of it. So that's the one that like we basically suggest our patients, and we tell our patients right off the bat, like after your surgery, I think when we see them, like a couple of days after their surgery, really we tell them straight up, like, you're going to be using that pretty much every 2 hours up until the day of your adjustment. And especially with the Canadian weather in the winter time, my God, the dryness is so brutal. It's so bad. The heat and just the dry air, it just kills. And I've like the type of dryness that I see now, like nowadays, I'm actually doing pretty much doing the adjustment on the first time when I see them. Versus when I saw them back in December and January, it's like, there's no way. And that's them after taking these drops for like every 2 hours. So yeah,
Do you
like
have
the
your
weather really
patients
plays a big part.
sign a different consent form that your LAL patients, or do they all sign the same cataract surgery consent?
Different.
Different?
I think we're the same. I don't think we have anything special.
Ours is the same as our all upgrade technologies. It's in a mix with everything else.
So have you ever thought of, only because I've had a patient that wasn't compliant with his glasses and then had to have explants because his lenses were changed.
Oh,
He liked them so much though, before the change, he got LALs re-implanted, but after that, we're like, who's on the hook then if they need an explant and another one? Like, do we have to bite the cost? Is it the patient? They were non-compliant. So I was just wondering if that would do you guys think that there should be something that they're signing, like, you are responsible, you need to keep these glasses on, as instructed, and use your tears, and this could, these are the things that could happen? Or do you think that's just a one-off?
I recently reviewed our informed consent for LAL because I was having patients who were coming back letting me know, not everybody gets 20/20 emetropic in a J2 situation, and kind of saying that the cataract surgeon promised them perfect vision at all distances. And I know the cataract surgeons aren't saying that, but I also know that they're talking about all the different options at the cataract eval, and patients just maybe remember bits and pieces. Anyway, when I reviewed the consent, ours is separate for LAL, and it talks a lot about the need for the tears and the sunglasses, as well as, no guarantee that they won't ever need some form of glasses. So it's just kind of extra reiteration, I think. I don't know if it helps, but then our surgeon also said that they would be really scared, I guess, to do an explant of the LAL because they're bigger. What is it, a 3-piece? But I guess it's good. We haven't been in the situation where we wanted to, but can't you also treat after lock-ins? I felt like I remember hearing that from the last call, even though we've never tried it.
Once you've completely locked in with number 2, you can't do it's locked in. They're done.
We were
And
talking
after they're
about
locked in, those lenses are much more brittle. They're much harder to cut. So we've luckily only had to explant 2, both for the same reason. Patient came in 3 months after surgery, never wore their glasses, and wanted to get a touch up. And that was after, actually, I think about one treatment didn't come back. But if you go to Asperis and listen to the guys that do explant these, they say they become a very hard lens after they get their final lock-in, and hard to explant. So this is their least favorite lens to explant from a surgeon standpoint, from what I hear.
So for this patient that actually,
go ahead. Sorry, I was going to say, on our consent form, we have, with your printer, you can highlight in yellow that with the LAL that they're going to likely have to have some glasses for certain distances, something to that effect, and they have to actually sign below that. So when they say, "You told me I'm going to be spectacle free," it's like, no, look what you just signed here. So that's helped a lot because it's he said, she said kind of thing.
Do you send the consent to them before?
Ours has task glasses everywhere.
Oh, nice.
The task glasses. Well, what is a task? Depends on what task you need them for. I don't mean distance, doesn't mean driving, doesn't mean near, it means sewing, knitting, whatever. You may need task glasses. And we have most of our referring doctors in their reports sending in, say, send in for upgrade lens, premium lens, LAL, and return for final check with prescription task glasses. And so they hear it from the referring doctor and us, and that's also helped limit that number of patients. You told me I'd never have to wear glasses again.
Jason, how'd you get that message out to your, because that's great that you guys work well with the community. I mean, we're constantly battling that, trying to get the message to be the same between me, my surgeon, I mean, the two of us as a team, but then also the ODs that refer. How do you convey that message and get that same kind of lingo and everything in line?
So we did, this has been probably 10 years ago when, multifocals really, maybe 15 years ago, when multifocals really got heavy. And we had 2 referring doctors that never sent a patient back for a touch-up PRK enhancement ever. And they were our 2 top referring doctors for upgrades. So they sent more upgrades to us recommended, and they'd never sent patients back for touch-ups. And so I took them both to dinner and I said, okay, give me, what is it? What's different? And if you read their recommendation in their plan, in their chart, it says sending in for whatever recommendation of surgery and RTC for us for postoperative care and final task class. And that was their term they came up with. Cool. And so I had them actually give a presentation to our referring doctor group. And they basically gave their spiel to everybody else. And that increased the number of referrals and decreased the number of touch-ups tremendously. And they got to prescribe glasses, and it wasn't a failure of the technology. It's a demand of the patient, because it's not the technology's fault, it's the patient's desire. And so they switch it to where, you're a type A sharpshooting architectural engineering pilot. You're going to need to see microscopic detail where Joe Farmer down in Okemah, Oklahoma is 20/60 and sees perfect. So his task glasses is he needs to, read his Bible at J1 plus print. But yeah, I actually had the referring doctors that did the best present to everybody else.
It's a great strategy. That's great. I mean, everybody wins. That's awesome.
Yeah. And we did because of this big co-management lawsuits that came out last year, we did a recent, update on co-management again. Because of the LAL, we have a higher co-management fee, or they collect a higher co-management fee. Mm-hmm. And we recently just went to COFI that collects all that. So it had opportunity to go through that same thing again. But we also went through, if you're collecting, $400 an eye, what are you doing for it? If an auditor came in and said, why are you collecting $400? What do you do differently? If you just see a patient, send them back, then you're not doing anything. So part of that is the determination before sending them back to us. So we already know what their target's going to be from contact lens trials, and they're going to see them back for final check and task classes. And that's part of it just kind of makes it a seamless discussion from start to finish.
Hey, Nick,
that's a whole topic. I think we should talk about that. Huh? Yeah,
it sounds like another talk. Yeah, co-management I think would be a good idea.
I think there's a lot of nuance there, and the line is so thin, between right and wrong with co-management that we should definitely have a whole thing on it, I think, because there's ways to take advantage of certain elements while staying completely compliant. And the LAL is a completely different thing, than what we've grown accustomed to. So that, Ryan, your head's right. We're great minds think alike.
Yeah.
Cool. Well, we're coming up on an hour. I mean, does anybody else have anything else they want to add? We didn't get to any more cases. I kind of figured that would happen.
I got a quick question if for you guys that are. So actually, we have our next meeting is next Tuesday, and we're introducing LAL Plus. We've only performed 2 at this point, and the surgeon that did it changed it the day of surgery because the rep came in the day before.
Perfect.
Both were basically LAL the dominant eye and LAL Plus the non-dominant eye, and that's what he pulled back from Ascaris. He wanted to be a little bit less aggressive. Even in their data, for their data sheets, they come out with LAL Plus. It does look like you lose a half a line of distance. Those of you that have used it, have you seen that if you're doing it bilaterally or?
No.
Okay, because their spec sheet in their presentation they send out, there's a higher percentage of J6, 2016, and then it's 2020 plus 2 instead of 2015 or 2016 at distance from the LAL Plus versus the LAL. So I don't know if that's just
it's the data. I mean, we were part of the study, and I think you give up technically 2 letters or so. Mm-hmm. There is technically a difference, and it's statistically significant, but we have not seen it clinically. The advantages far outweigh the negatives with it. There's really
Okay.
not much compromise. So we do it bilaterally, and we just stay away from it from highly compromised corneas. Significant dry eye for now. We do it in LASIK patients. RK, we'd stay away from it, keratoconus.
Okay. Okay.
Cool.
Does anybody take an account, or is there an account? I mean, our PanOptics and other multifocal lenses have an L-disc or an angle kappa. Is there a concern with a very large L-disc greater than 0.7 or something that you would look at for like a Vivity with that central button being off center?
I don't think so.
Okay.
I really don't think so. It's such a smooth transition.
Okay.
And I haven't read anything about that being a concern. I haven't read
Well, I
anything about angle kappa being a concern with this.
Okay.
I haven't seen it.
Okay.
Anybody else? Any other feedback? No. So I guess no.
Not that's yet been disclosed.
Not yet. Yeah, we may talk about that on a different.
Yeah.
But
Give us
for
6
now,
months.
Awesome.
cool. Awesome, guys. Well, appreciate the talk. I think a lot of good discussion. We covered a ton of ground. So, yeah, keep a lookout. We'll do another one of these in the next month or so. And I mean, these discussions just flow, and I definitely appreciate the contributions. Awesome.
Nick, thanks for putting this together.
Yeah.
Great seeing everyone
Yeah,
again.
Bye, guys.
All right, take
Have a
care,
good night.
everyone.
We'll see you guys later.
Thanks,
Take care,
Jess.
guys.
Bye.
Bye.